Arthur Kaufman, University of New Mexico. So 90% of the US healthcare dollar goes into a health system that affects only 10% of what makes us healthy or sick. The vast majority, a much greater amount of that health and illness is related to the social determinants: education, income, poverty, nutrition, transportation, housing, social inclusion. Physicians know this. There was a massive study of 1,000 docs by the Robert Wood Johnson Foundation, and what it showed is 4 out of 5 said, I know that social problems are as important as medical problems. I don't know how to address them. The health system does not help me in addressing them. And by the way, this is not just for poor people. So how do we address this? One of the dilemmas is that the US spends more than any other Western country on health, but it has the worst health outcome. And one of the reasons is, despite the fact that the total amount of health and social services we spend is about the same, it's about average for other Western countries, we spend a wild disproportionate amount on the health system and too little on the social service system. And it's that social service system that would help address the social determinants, the biggest cause of our illness. So how are we going to address this and move some of the resources that are in our health system upstream to address social determinants? And what kind of incentives would there be to actually do this? We talk a good game, but what do we actually do? Well, what we've tried in New Mexico is to use community health workers. Community health workers are every place in our communities. Most of them are high school trained. Some have some college. They are culturally, linguistically competent. They know their communities better than anyone else in our system. They're from the communities, and social determinants is their primary focus. Their credibility is not because of a professional diploma on a wall, but because of, as we've heard, trust. The trust that their communities have in them is so far greater than they have in our health system, the health system that even works in their communities. So we build on that. The question is, how do we influence our clinics and our clinical system to value social determinants, understand its power in influencing what we can and can't accomplish in our health system, and to value the role of community health workers in that system? So what we did is we came up with a social determinants prescription pad. We asked our social determinants experts, that is our community health workers, what are the 10 or 11 most common problems you see? And we came up with this list. It's got all the things you all know about. But then we started to question all of the patients, every single patient that came in to the university primary care clinics and our biggest community health center in Albuquerque. And what do we find? Almost half of our patients had at least one adverse social determinant. And over half of those had more than one. And virtually none of these were known by the clinic, because we never asked those questions. Now, what was the upshot of this enormous, unforeseen, unknown, adverse social determinant within our clinics? The hospital hired 2 community health workers for every single clinic, and the community health center hired 2 for their clinic. And their roles were dual. They were the agents within the clinics who elevated knowledge about community social determinants to all community health workers. The front desk began to screen for it. MAs screened every patient, and when there was an adverse social determinant, it was referred to the community health worker that was in the clinic. There was an external spanning role. bridging role in which community health workers work with their community groups, and those groups began to have more access to the clinics, whether it's social service agencies or community health workers that were based in the clinic. So there was a good exchange back and forth. Now, this is the funding source that becomes so interesting. Managed care became very interested in this. Medicaid managed care in New Mexico, and it's a poor state, so we have about 35 to 40% of the state are on Medicaid and rising quickly. We are an expansion state. Realized that if they could employ community health workers to address the high-cost top 5% hotspotters, they could save a lot of money. There are 4 Medicaid managed care organizations in New Mexico: Blue Cross, Molina, United, and Press. All of them contract with us to hire, train, and deploy them. And they have saved a huge amount of money. Decreased ER visits, hospitalizations, drug costs, increased use of primary care. And there's a 4-to-1 return on investment. That is now spread all across the state, and 10 other states use this model. Community health workers addressing social determinants, saving money. In the clinics, the role of the community health worker has increased further. They now are the primary teachers of adverse social determinants to our students and residents, as you see here. They now enter their findings into the medical record. We now have Z codes. Every single social determinant has a new Z code, which can be entered, and that's important for billing. It's important for tracking, QI, meaningful use. This is all generated by the fact that community health workers are in our clinics. This is just a list of what those Z codes are. Now, most of what we hear about interventions in social determinants have to do with hotspotters. The model of working with the most difficult, complicated patients, where using community health workers, others, improves their care, decreases cost. It is fantastic, and it has no impact on population health. The investment is way too downstream. I feel like Marco Rubio. So what happened was we have now worked with Molina and Blue Cross and state Medicaid to say, why don't we take this model of community health workers working with social determinants, and not just the top 5%. Our data shows that works, saves money, but with the whole population. And so we're studying this with 10,000 patients, with all categories, to see if we can prevent patients who are healthy becoming sicker, patients with chronic disease becoming the top hotspotter category. Prevention, community work. And what we've done is hired a actuary firm. We have health economists making a projection of what the cost saving would be. Here's the data. As we move along this course, if we are anything like this outcome over the next year, the cost saving by investing in addressing social determinants with community health workers is far greater than the cost savings of another important innovation, the patient-centered medical home. These are complementary. But we have to look at the power of this as a funding source as well as a population health innovation. Thank you.